So thank you. Thrilled to have the invitation to be here to speak to you about a practical, and I should have put in parentheses, brief guide to treatment cessation. We'll run through some of the data that we have and some of the future data. These are my disclosures. And I think these are some of the questions that come up, which is when is it safe to stop? So not when are you forced to stop, but when is it safe to stop MS-DMTs, and what factors into your decision to do it, and how should you monitor the patient after stopping? And I think honestly, this is it's a product of our time that we're in that this is even a question. So we sort of spent the first 25 years in MS arguing for early therapy and trying to improve the diagnostic criteria to try to get as many patients who could benefit from therapy on therapy as soon as possible. And I spend actually most of my time arguing in favor of highly effective early therapy, getting people on the most effective early therapy early on in their disease. And so for me to give this talk sort of seems a little bit strange at first blush, I guess. But really these goals aren't all that different, because what we aim for is really the right treatment for the right patient at the right time, and are moving toward what we would call flipping the pyramid. So rather than saving potent therapies until the end of MS when you've realized that things have gone bad, using the most highly effective therapies early on when we know that they're likely to be the most effective, and then potentially backing off after a critical period has passed. And we'll talk about when that might be. And so that's that idea of kind of flipping the pyramid. So the question of can or should we discontinue disease-modifying therapies really relates to people aging. And in the US, 25% of our population is older than 55. And however, we have little data to really guide what we do here. There are some observational data, but really it's pretty scant, and we'll have a look at some of it. So, why would we consider stopping disease-modifying therapies? Well, one reason might be side effects, and I'll use interferon as the prototype example because it's actually my favorite disease-modifying therapy to stop, because you can make people feel better. And so people who have been on interferon for 20 years have developed some secondary progression, or superimposed progression as I would prefer to call it, and have developed some spasticity and fatigue and other symptoms of MS. Those things can be made worse by interferon. And this is the one piece that I would encourage everyone to be vigilant about when they see patients who have been on these therapies and are still on these therapies at an older age. This is a look at some of the betaferon data from the BENEFIT trial and then the BEYOND head-to-head trial, and then also data from the 16-year long-term follow-up of betaseron, looking at the prevalence of side effects like depression, flu-like symptoms, injection site reactions, and malaise. And you can see that these numbers are quite high. And these are percentages. And over time, many times patients become accustomed to these and don't even realize that they're living with things like fatigue, depression, or worsened spasticity, which isn't on this slide, but I think clinically many of us recognize that interferon can worsen. And so I think this piece of this puzzle, which is when the patient is experiencing side effects of the therapy, needs to be integrated into the decision. And I think it's a particular issue with interferon itself. What about other reasons why we would stop? Well, one would be infectious risk over time. PML seropositivity we just heard about. Cancer incidence increasing with age we've heard about as well. Hypertension with certain therapies, especially fingolimod, and long-term effects of newer DMTs are really unknown. So because of all of these reasons, this may become a more contemporary issue as time goes on. Cost is certainly a factor, and so this is this famous curve of cost of DMTs in the US from 1993 through 2013. It's going up exponentially. The MS therapies are going up disproportionate to other treatments for other autoimmune diseases. And the patient bears some of this cost. So in the US, when someone becomes a pensioner at age 65, they're actually on the government insurance plan meant to bear 20% of the cost of their medications, whereas if they were on private insurance prior to that, they wouldn't necessarily have to bear that proportion, or they'd be eligible for copay assistance foundation help. And so cost is not an insignificant issue here. Outcomes in patients who have stopped disease-modifying therapy have been an interest of a few groups. One of the main ones that you'll see on a few of these slides, Ilya Kister from NYU in the US. And this is actually an observational data from MS-BASE, observational data looking at so-called stoppers, 485 of them, versus those who stayed on DMT. These were largely young, heterogeneous groups, so mean age of 45 years. And they were selected from MS-BASE because they had no relapses for 5 years, and they were followed for 3 years after their DMT stop. And they stopped for many reasons. Most of these were patient or physician choice. And there are a few key findings here. One is that 1 in 4 of the patients overall relapsed in the study. And the rate of relapse actually wasn't much different between those who stopped and those who stayed on disease-modifying therapy. So even those who stayed on were having relapses as tagged in MS-BASE. Second was that there actually was a difference in time to disability progression that was shorter in the stoppers. So those who stopped disease-modifying therapy were more likely to get to disability progression milestones sooner than those who stayed on. So this group on the whole did not do all that well, actually, and it was a fairly young group. And it was large and heterogeneous. So there's a lot of interest in looking at factors influencing then, well, maybe we can tease this out and select patients who might do better or might do worse, or should stay on or should stop. And a few factors have really come out here. One is age at baseline. And so age at baseline is one of the factors that probably predicts, this is a large study, 4,842 patients who used 12 or more months of DMT prior to discontinuation. And age at baseline is one of the factors that predicts whether or not somebody's going to relapse after stopping their DMT. In fact, there was this is a hazard ratio of 0.97, which doesn't look all that unusual, but that's for each year of age at baseline. And so there's a 3% lower risk of relapse for each additional year older the patient is at baseline. And so as you go from the mean age here, median age, which is 35, older by 1 year, 2, 3, 5, 10, 20 years, that risk declines substantially of additional relapse. And also the patient being relapse-free for more than 1 year pre-baseline was a factor that was identified as well. Stopping DMT in clinical practice is something I think we've all tried. And this is a report from Gary Birnbaum in the US, which looked at patients who were either advised to stop by their practitioner or patients who chose to stop on their own. And in the patients who were advised to stop, age in the group who were stable was significantly older than the group age in the group that worsened by about 5 years. And so in this work also, age was one of the factors. Notably in this group, there was no relapse or scan change on many of these patients between 2 and 20 years of follow-up. And this is a single clinical center experience. Again, looking at factors that may predict stability. This is from an Austrian database where there were 221 patients who stopped. Again, these patients were not all that old. They were 38 years old. 44% of the patients relapsed and 21 progressed. But again, the major factor predicting who that would happen in was age. So age greater than or equal to 45 years and absence of relapses. Age and stability being consistent factors predicting who is going to remain stable after stopping disease-modifying therapy. So this really shouldn't be too much of a shock. So there's actually substantial data now showing that treatment effect of MS-DMTs is in part age-dependent. So this is a meta-analysis from Helen Trumlett's group in the US, looking at all the major the active arms of all the major clinical trials, where the circles are proportional to the size, the number of patients in the trial. And this is the inhibition of disability progression on the y-axis and versus the average age of the patients in the trial on the x-axis. And you can see here that there's a trend for the older the patients are, the lower the effect on disability in these trials. And what you can start to do is maybe draw a line and figure out an age around 53 years here where there's no effect on disability, theoretically, even though, again, it's hazardous to extrapolate out to a part on a curve where you have no data. You can start to see this trend between maybe the window of opportunity for treating MS with the disease-modifying therapies is earlier on, and that later on the utility, that is the benefit that the patient derives, at least in a group analysis, lessens. And that's the caveat here, right? This is a group analysis. Of course, we've all seen the patient who's age 70 and still has gadolinium-enhancing lesions or presents with a transverse myelitis, and it's not a paraneoplastic syndrome. And so there are, of course, exceptions to the rule, but this is probably the generalizable rule. The other factor that we talk about is whether stopping one disease-modifying therapy is the same as stopping another. So is this treatment dependent? Is stopping interferon the same thing as stopping glatiramer acetate, is the same thing as stopping natalizumab? And the answer is probably no. Because stopping disease-modifying therapy and looking for the return of disease activity probably is DMT dependent. So if you look from the study that I showed you earlier, the other factor that was identified was that the hazard ratios were quite different for interferon and glatiramer patients who were less likely to develop return of disease activity compared to natalizumab and fingolimod. So these are some early signals from observational studies suggesting that this is the case. One question that's arisen is whether return of disease activity after stopping natalizumab is actually in excess of the baseline disease activity. And so this is a study published in 2017 showing the proportion of patients, of these 15 natalizumab patients who stopped natalizumab, 11 out of the 15 incurring significant new disease activity over 19 months of follow-up, showing that about a third of them experienced what they termed rebound or disease activity that was viewed in excess of their baseline disease activity. About a third were stable, and about a third had a relapse. And of the injectables, the control group who stopped injectables, in comparison, about 2/3 of those patients were stable. So again, showing this likely difference between stopping something like natalizumab and stopping an injectable. And so we've already seen this figure that David Clifford showed, but natalizumab is likely a special case. And I'll show you two special cases this morning. This is a study that, a randomized study that Ludwig Kappos coordinated, where patients were randomized to different periods of washout before switching from natalizumab to a different disease-modifying therapy. And you can see by the survival curve, and this is patients without new T2 lesions. This is MRI disease activity, which is the primary outcome measure in this study. You can see that that disease activity began to return approximately 12 weeks after stopping natalizumab and continued on through about 24 weeks through the follow-up period. And in this study, you could see that the group with the 16-week or the longer washout period was more likely to have more lesions following natalizumab discontinuation. And so this is one of the reasons why switching from natalizumab to another disease-modifying therapy, we keep the washout period quite short. In fact, probably even a length of time that wasn't studied in this study, approximately 4 weeks. More data from a study called the RESTORE trial, 175 patients. And this tested, well, could we do something about that return of disease activity in patients discontinuing natalizumab? So at time 0, all of these patients either were randomized to, all the patients were randomized to either stay on natalizumab, and that's the blue line, and they have no further disease activity, or go on one of these, switch to one of these different therapies, either placebo intermuscular interferon, glatiramer, or pulse methylprednisolone in a little bit of a strange dosing pattern. And you can see that each one of these, except the interferon group, actually had return of disease activity. And the thought was that this is actually probably too small of a sample size to extrapolate any guidance about putting patients on interferon to try to suppress disease activity following cessation of natalizumab. But again, you see this timing. Right at about 12 weeks is when things start to happen. Fingolimod is also likely another special case. And so this is a case series that was published by the UCSF group, a meta-analysis of different cases that had been published in the literature showing a return of disease activity that would qualify for rebound, or in other words, disease activity in excess of what would be expected. And it's fairly idiosyncratic, so it's rare. It can occur 4 to 16 weeks following cessation of fingolimod, and it may or may not respond to intravenous steroids. And I'll show you one case from our clinic because we've seen a couple of these as well. This was a 28-year-old woman who discontinued fingolimod because she was going to attempt to become pregnant. 2 months later, she presented to the emergency ward with very severe vertigo and had an MRI scan that showed severe disease activity. I didn't show you all the GAD-enhanced images here and things, but take my word for it that many of these lesions are GAD-enhancing and look quite edematous on the flare sequences. And so she was admitted, required inpatient care with IV methylprednisolone and Plex, and thankfully made an excellent recovery. But this is something that you need to be aware of when stopping fingolimod, that this sort of idiosyncratic reaction can occur. And so for that reason, we don't just stop it for no good reason. Well, what's one of the good reasons that we usually recommend stopping disease-modifying therapy? It's in women who want to become pregnant. And so we're often tasked with counseling patients and giving preconception guidance, and it's a big challenge. And I would say that this is one of those situations where there's not a one-size-fits-all solution for most people. It really requires a conversation between the patient and the physician and potentially the OB as well. But here's kind of the long and the short of it. We generally feel as a field that glatiramer acetate is likely safe to continue through conception. Interferon is also largely regarded as safe, though in the early studies it was found to have a mild abortifacient effect. So because of that, it's typically stopped in advance of conception. Oral disease-modifying therapies have less data, and we typically advise stopping those, and it's reasons like that that tend to get the patient, like on the last slide, into trouble. And so we've moved maybe to a different strategy, and that's using B-cell depletion through conception and pregnancy. And there have been, there's actually a case series and a literature review on this in MS, if you want to look it up in the N2 journal, where UCSF group reported 11 pregnancies in 10 women. It's not a large experience, but it's something. And the idea here, the concept is that you can treat someone with a drug which is relatively short-lived in the system, 2 to 3 months, and has a long-lasting benefit. And so you can dose someone, they wait 2 to 3 months to conceive, and then they get a period of no disease activity where they're protected from their MS, and they could potentially conceive without being on any medication and without having to worry about severe rebound effects. And so many of us in the US are moving towards B-cell depletion as a potentially appealing therapeutic strategy for women in childbearing age. I know there's also case series and guidance given by the German group at ECTRIMS last year, I believe, talking about continuing Tysabri through pregnancy. We do not do that generally in the US. And then finally, alemtuzumab as an option, again, an appealing option in women of childbearing age who want to have a short-acting, sort of short burst therapy that may have long-lasting benefits, though that's not as popular in the US also. So if you're going to stop, what should you do then? Because you shouldn't just stop and leave the patient high and dry. Most of us would want to monitor the patient. And so generally what we do is we increase the frequency of monitoring. So if someone's been on medication for 20, 25 years and they've been doing okay, and we're going to stop. We usually increase the frequency and we do an MRI scan perhaps every 6 months for the first year. And if things look stable, backing off a little bit after that. And we always check an MRI in transition from natalizumab to another disease-modifying therapy, and it's the one thing that we're fairly strict about. And so we feel comfortable having short washout periods after natalizumab if we have an MRI scan in that interval after the patient stopped natalizumab, but before we're going to start something else, that we can look at and show that there's no radiologic signs of PML on that scan to reassure ourselves that we're not going to have, or at least to the best of our ability, reassure ourselves that we're not going to create a carryover case of PML, especially if we're giving a long-acting therapy afterwards. So we do have some guidance from our professional organizations. The American Academy says that in SPMS, you should assess the likelihood of future relapse, and age and disease duration and relapse history and MRI activity should all factor in. In SPMS, clinicians may advise discontinuation in SPMS patients who do not have ongoing relapses or enhancing lesions and have not been ambulatory for at least 2 years. It's relatively low-level evidence, and I would say it's not generally followed too much in practice. The EAN guidelines recommend considering continuing a DMT if a patient is stable and shows no safety or tolerability issues, though, as Gavin was mentioning, I think the payers feel otherwise in a lot of these situations. Where the professional societies leave off, we try to fill in the gaps a little bit. At our institution, we sit around a table and talk about these issues. And if you're interested in hearing sort of more kind of single institution level guidance on these things, you can Google a series of documents that we've written called Mellon Center Approaches, because there are about 10 of us neurologists who sit around a table and talk about all these issues. And you could, publicly available, you can just sort of get our take on these things if you're interested in knowing how we do it at our center. Just wrapping up here, there is opportunity for future evidence in this, and this is actually an exciting trial, the DISCO MS trial, which is a PCORI-funded trial. And it's going to randomize 300 participants at 15 sites in the US. It's a little over halfway enrolled right now. These are inactive patients, so no relapses or any scan changes for 5 years. They can have relapsing or progressive MS. And it's going to be a 2-year follow-up with percent new relapse or new T2 flare lesion being the primary outcome measure. Also looking at EDSS change in patient-reported outcomes. And a planned interim safety analysis of the first 50 participants in the study said, things are looking good, continue the study. And so we think that this is a valid question to ask. It's an appropriate setting for a trial. Hopefully we'll have a better answer for you in a couple of years. So here are my key takeaways. I think that DMT may potentially be safe to stop at some point later in life, but we don't know the exact threshold. There are some arguments in favor of doing it. Special cases exist. We talked about natalizumab and fingolimod. And emerging data are yet to come. And finally, the other piece that was brought up yesterday with regard to starting DMT is probably equally true for stopping it as well, is that we don't often measure things like cognition, brain volume, and other more subtle effects of the disease that are less clinically obvious than relapses and gadolinium-enhancing lesions. And I don't think, as people live longer and longer and longer, I don't think we know that stopping a disease-modifying therapy at age 50, even if the patient's not having relapses or not having GAD-enhancing lesions, is going to, whether or not it's going to potentially affect these other more sensitive factors. So hopefully we'll see some work on that in the future as well. So that's all I have, and we can have questions and hopefully lunch.